Great. Welcome back to House Healthcare after that short break. Now we have Jen Carby, our legislative counsel, to continue our discussion on PBMs. And Jen, I think you do have a presentation on our committee page.
And I will put it up on the screen if that works.
Yep.
I can make this thing move. Do it as a slide. There we go. All right. Great. So good afternoon, Jen Carby, Legislative Counsel. For those of you who were on the committee last year, this will look quite familiar. I just updated it a little bit, but it's really an overview, a little bit more focused on PBM. So I think what you heard from Sebastian was a great place to start because he gave you the landscape, have some context, and then we'll talk a little bit more specifically about PBMs, and then you'll hear more from the Department of Financial Regulation later in the week, and we'll go from there. So first off, what is a PBM? And some of this will be a little bit of repetition from what Sebastian went over, but I think it's still useful. A PBM, or pharmacy benefit manager, is a company that manages prescription drug benefits on behalf of those payers that Sebastian was talking about. So that could be health insurer, it could be a self-funded employer plan, it could be Medicaid, Medicare Part D, or other payers. The point is that they are contracting with a pharmacy benefit manager to manage their prescription drug benefits. And they serve as an intermediary between the payers and the prescription drug manufacturers. So I think you saw that on Sebastian's chart. The three biggest PBMs in the US are Express Scripts, CVS Caremark, and Optum Rx, which is a division of United Healthcare. And they have more than 3/4 of the market share. Some sources say it's been as high as 89% in recent years. You may have also heard there's a lot of focus on this going on at the federal level right now. The Federal Trade Commission has launched a study on PBMs. And just recently, the House Oversight Committee, which actually our new Representative Ballant serves on, is also looking into it and has asked for a bunch of information from the biggest 6 PBMs. And they set the level at about 80%, that these three companies have about 80% of the market share right now. What does a PBM do? Well, the PBM does a number of things, some of which Sebastian talked about already. They administer the prescription drug benefit for the health plan. So they kind of take over that piece on behalf of the health plan, and they do the claims processing and member support, but just specific to the prescription drug benefit.
Just a quick question,
Sure.
and this might help me in my saga here to understand this. The payer, say, whatever one, they pay a yearly or monthly fee to the PBM just for their service?
They pay for the service. I think there's different structures, and Sebastian may be talking more about that on Thursday. Different payment structures. But in general, yes, it is a service there that the payer is paying the PBM to provide.
Okay, so it's like a premium, say?
I wouldn't use that term because I think it's confusing.
Don't get into the weeds.
I'm going to go for the Department of Financial Regulation. We're going to talk about this more on Thursday, but in general, they can pay it like a premium, an administrative fee, or they can pay it based on the difference between what the health insurer is reimbursing the PBM and what the PBM is reimbursing the pharmacy.
Okay. All right, we'll wait till later.
Yeah, so there's different payment models, and some states have looked at putting some requirements around what can and can't happen in some of those contracts. We have certain provisions that deal a bit with the contract as well.
I just wanted to see if there was a flat fee that got charged every month or every year.
Awfully simple when we're talking about prescription drug costs, but all right. So what else does the PBM do? They develop and maintain the prescription drug formulary, that list of drugs covered under the health plan. And Sebastian was talking to you a little bit about some of the methodology behind that and how that interacts with the negotiations with the manufacturers. PBMs negotiate rebates and discounts from the prescription drug manufacturers in exchange for including their drugs in the formulary, as you know. They also implement utilization management tools. So they might use things like prior authorization, step therapy. Step therapy is where a patient has to have tried drugs in a certain order. So you can't automatically get a more expensive drug if you haven't tried a cheaper drug for the same condition and failed on that drug, and then you're able to advance to sort of the next step. Was that a question? Okay.
No,
Just okay.
not at all.
Just check. So they also might impose quantity limits. There are a number of utilization management tools that PBMs employ to try to keep prescription drug costs contained.
And I have a quick question.
Sure.
And just to confirm, the formulary can be different for each health plan.
For sure, yes.
It's not just like one formulary that all health plans have to follow. It's based on that.
We've been talking in the past about creating a statewide formulary, but no, all the formularies are different.
Specific to, okay.
Yes, and I invite Sebastian to jump in if I'm mischaracterizing anything. He's spent a lot of time in the weeds of this issue.
Yes.
If I can follow up on that question, could the formulas change within the health plan itself? You know, you have different levels, and the formulary might be different at each level in the health plan?
You mean for each, like depending on which insurance
silver,
plan
bronze,
you
silver,
have?
whatever.
The differentiation in those are really about the benefit, about how much you pay out of pocket versus how much the plan pays. So I wouldn't see them changing.
Yes, so at a big level, while you could have a different formulary for like Blue Crosses, silver and bronze, they don't. All of the qualified health plans, which are the plans that are sold on Vermont Health Connect, have the same formulary. What can change is that drugs can go up and down on the formulary tier, and that's actually quite common.
Okay, so maybe talk about what that means on the tier.
So remember that in our simplistic example, that each formulary tier corresponded to a different amount that patient had to pay out of pocket. So if a drug is moved from, say, tier 2 to tier 1, then that patient might have to pay less out of pocket when they get that drug at the pharmacy. Conversely, if it moves from tier 2 to tier 3, they might have to pay more.
Can I just clarify, are you saying it might be tier 2 for a silver plan and tier 3 for a bronze plan, or you're just saying they might?
I'm saying that the same drug might move between tiers, not that different plans using the same formulary would have different drugs on each tier. Does that make sense?
So for instance, let's say you're using a lotion for dermatology and currently it's on tier 2 and I have ABC health insurance. The next time I go to buy it, it might now be on tier 1.
Exactly.
And the price might change and you say to your pharmacist, well, why the heck did the price change? Because of that.
There
Okay.
is some language in our laws about changing formularies and how often that can occur.
And so just so everyone knows, when we come back to this, there's gonna be time where we do with Sebastian again to go over the report that was set out in Act 131. And then we're also gonna spend time again with Jen to go over what's currently in statute here.
That's good. Thank you.
Yeah.
Okay, and then another thing that PBMs do is they contract directly with pharmacies to reimburse them for the drugs dispensed to plan beneficiaries. And so those are the different arrows or different lines that Sebastian was showing you about the PBM's interaction with different players in the system. And the PBM establishes that maximum allowable cost for each drug, the MAC price, which is the price that the PBM pays to the pharmacy for having dispensed the drug to the patient. All right, so here was a pre-drawn picture of some of the money in the system with kind of a PBM centric view. So you can see the PBM in the middle and all the different players that they are involved with, but you can also see that these descriptions are really the same ones that Sebastian was showing you on the chart that he drew, just talking you through it at the time. So how are PBMs regulated? Vermont currently requires PBMs to register with the Department of Financial Regulation. The bill that was passed last year when it was introduced would have established a licensure requirement. The bill that is on your wall on this topic this year, H233, would also establish a licensure requirement. And whether to have a licensure requirement was one of the issues that the legislature last year directed DFR to meet with stakeholders and come back and report on. So that will be, I'm sure, part of what Sebastian goes over on Thursday. There had been some lack of clarity, the extent to which states could regulate PBMs, particularly when they were doing the pharmacy benefits for a self-funded company, employer plan. But in 2020, the Supreme Court of the United States took up the issue of both pharmacy benefit managers and ERISA, which is the federal law that governs self-funded employers. And in a very weedy decision, they held in that case, Rutledge v. Pharmaceutical Care Management Association, that an Arkansas law that basically required PBMs to reimburse pharmacies at least the pharmacy's wholesale cost, what they got it from the wholesaler for, was not preempted by this federal law, ERISA, that often preempts, has a very broad preemption clause that preempts a lot of state action in areas that touch it all on employer-sponsored plans. So the two takeaways from that one, which mean the most to you if you have spent a lot of time with ERISA issues, but there was no impermissible connection with ERISA plans because cost regulation, which is what Arkansas was looking to do, does not dictate specific coverage requirements. So it wasn't getting into plan design, it was really getting into cost regulation about how money had to be paid between the PBM and the pharmacies. And then it did not refer to ERISA, which is a specific no-no in the ERISA preemption clause, because Arkansas law was not dependent on the existence of ERISA plans. It didn't care what type of plan you were. It was really looking at what the PBMs were doing and how that was affecting the pharmacies and the availability of prescription drug services and prescription drugs to Arkansas residents. So that, I think, has emboldened a number of states to go further than they had in the past. And many states have created or revised or are looking at doing some licensure and registration requirements or otherwise looking to increase the regulation of PBMs. And I have some links in here to resources from NCSL, the National Conference of State Legislatures, and also to NASHB, the National Academy for State Health Policy, that looks at what a lot of states are doing on these issues. And then, as I mentioned, the federal government is taking a keen interest in this as well and using some fairly fiery language in some of their communications about their concerns about PBM impact, access to prescription drugs, prescription drug costs, healthcare system costs, and otherwise. Some of the big issues that come up time and again when we're looking at PBMs and PBM regulation, one of them is spread pricing. So as you heard from Sebastian, the PBM is reimbursed by health plans and employers, and typically that's at a higher price or can be a higher price than what the PBM pays the pharmacies for their drugs. So if the PBM gets more from the health, it gets reimbursed more from the insurance plan than it had to pay out to the pharmacy for the drug, and the PBM keeps the difference, that's called the spread. That difference is the spread, and spread pricing is a way that many PBMs, depending on the way their contracts are structured and what the state laws allow, that's the way they often make a lot of money, is through the spread pricing. It can be a small amount on a prescription basis, but it can really add up through volume. So spread pricing is one issue. Rebates are an issue, depending, again, on the terms of the contract. PBM may be required to pass through to the payers some, all, or none of the rebates that they get from the manufacturers. So in some cases, that's where PBMs are making some of their money, or it may just be a straight pass-through. Clawback, if the patient's copay, so the amount the patient has to pay out of their pocket, is higher than the amount that the PBM reimburses the pharmacy for the drug, and sometimes the PBM claws back the difference from the pharmacy. So they basically say to the pharmacy, you made too much money on this, give us some back. And you may hear from pharmacies about their frustration with that.
Leslie?
I'm just curious about when you use the term pharmacy, are you thinking about independent pharmacies or the bigger chains, or do these things apply across both those ideas?
I think the concepts apply across both. The actual financial incentives or how the money flows may be different when they're all kind of an in-house versus the smaller pharmacies that aren't part of a PBM, aren't financially affiliated with a PBM.
So if I may, the PBM that owns their own pharmacy, they have their own arrangements, probably not a lot of money moving back and forth. But if it's an independent pharmacy with the smaller chains, they may have a larger desire to claw back.
I can't speak to the specifics of how it works, mostly because I don't know, but I also don't want to,
for sure.
impugn anybody's business practices.
No, I
based
wasn't.
on my lack
I
of
just
knowledge.
wanted-
So I don't know the answer.
We're gonna, Maury, raise her hand so she might have a comment.
I'm going to hold it. I think it's about the impact of clawbacks
Okay,
and
Yeah,
threat
that's-
pricing, but I
Yeah,
think
that
I'm
came
gonna
up
wait
last
a
year.
little bit.
yeah, let's hold off on that. Thanks, Maury.
All right, and then gag clauses, and we addressed some of this in the law that was passed last year, and we had some provisions in effect before that as well. But gag clauses are where a PBM might, through the contract, prohibit a pharmacy from telling patients things like when the cash price of a drug would be less than their copay amount. So saying, hey, you'd actually be better off to just buy this for cash than running it through your insurance. Or telling patients about lower cost options or things like that. In 2018, Congress did pass a law prohibiting gag clauses regarding the cash price being less than using insurance. But otherwise, there has not been federal regulation on this that I'm aware of. But as I said, the state has done some, and we will look at that when I next come back on this. And I think that was it. I think the only other thing that I would just add, and you may be able to get some sense of it too from both from the picture and from what Sebastian went through with you, is just there are different perspectives depending on who you are about the role that PBMs play. You may hear very positive things about them from insurers, and you may hear other experiences from pharmacists and others in the system. So I think it sometimes depends on where you sit and what the perception is. But I just want to put that out there. There are different views.
Thank you for that, Jen. That's important for us to remember. Maury?
I'll just add in something that we'll, I'm sure, talk about more. But to deliver those issues.
I think you froze, Maury.
Include the
Hey,
power
Maury,
that-
Maury? Yeah, there you go.
Yep.
Can you start over?
Yep, so I would just add to the list of the issues we're looking at addressing the power that PBMs hold over the formulary and how they use that to direct business to their entities. Were you able to hear that?
We heard it. Not sure we understood it. Could you say that again?
So
Or I didn't understand it.
PBMs create formularies and they control what's on that formulary. If the insurance that you have, if the PBM associated with that insurance hasn't chosen to put that drug on their formulary, you will be forced to use a medication, a different medication, not the one that your provider prescribed for you. Does that make sense?
I see some people nodding heads.
Unless you want to pay for it.
Right. If you knew, if you were able to access that information and you knew that it might be cheaper to just, if you wanted the medication and pay for it out of pocket. True. It's so complex, but I just wanted to highlight that as one of the problems that PBMs are directing business to their own entities by controlling what's on their formulary.
Great. Thanks, Maury.
Yep.
Bobby?
Just to ask, so Mari, what you're saying is that they decide what drug you're getting instead of what your provider chooses for you.
Exactly. That's a simplification of it, but yes, that is what ends up happening.
Yeah, okay. Thank you.
Any other questions for Jen or Sebastian?
I struggle with this, and I struggled last year with it in terms of how the local pharmacy is hurt by the practices of the PBM. Or Jen, I mean, I don't know if, I know we
So-
heard this a lot last year.
Yeah, so
It does happen, but I
if Sebastian wants to answer, that's fine, but I will also say
Right.
we will have local pharmacists
Gotcha.
come in and talk to us.
Yeah, at the most basic level, and Sebastian, we're gonna go for the Department of Financial Regulation. The local independent pharmacies are hurt when the MAC price, the maximum allowable cost that the PBM pays to them is less than what they had to pay at wholesale to buy that drug, which means they are losing money when they dispense it. There are other factors too with respect to large chain pharmacies. So for example, independent pharmacies typically don't have a whole convenience stores worth of stuff for you to buy, and they don't have that revenue stream coming in like the CVS's and Walgreens of the world. But on the pharmacy side of the business, it's when the MAC price is less than the wholesale price. That's when they really get hurt.
Okay.
And can I, sorry, so I just want to clarify. So again, the pharmacist is buying the drug from the wholesaler, and because it could be, if it's an independent pharmacist, they're probably paying more for that drug at the wholesale price than a national one.
That's
Right, and so then that could also make it even more of a spread between the MAC price and the wholesale cost. Okay,
Yeah.
thank you.
How does the generic drug fit into this? If the PBM has a formulary, and then I go into the drugstore and I get a drug, I'm looking for a drug that's on the formulary, and then I end up walking out of there with a generic drug.
Well, generic drugs are typically cheaper. We do have a generic substitution law that requires a pharmacist to substitute a lower cost drug if it is a true if it is a true therapeutic equivalent, as you know, as determined by the FDA. Am I coming up with the terminology right? But how that fits with where PBMs put drugs on their formulary, I think generic drugs are typically in the cheapest plan tier, but otherwise I don't know. I don't know how they would set this up.
This is, again, Sebastian, we're going to go for the Department of Financial Regulation. This is something that will very much depend on the specific formulary at issue. But Jen is right that in general, generic drugs are on the formulary tier that has the least patient cost sharing.
And we make that decision. The legislature makes the.
So what Jen is referring to is
We have to stop for a second.